Hello there. Now that you've had the lecture on the different pathways of vitamin D, calcium, parathyroid hormone, we're going to talk about more specific diseases. And these are vitamin and mineral deficiencies effect on bone. So specifically osteoporosis, rickets/osteomalacia, and scurvy. So osteoporosis/osteopenia, this is really common right after the age of about 30. So once we start getting into middle age and later, we have an imbalance of deposition and resorption, leading to bone loss. So we have more resorption of bone minerals than we have deposition. And that amount is roughly 8% per decade for females, 3% for males. So females are more at risk of osteoporosis. And the definition of osteopenia is just less than peak bone mass. If I'm describing a radiograph, I might describe it just as appearing osteopenic, but I'm not going to diagnose osteoporosis from a radiograph. We'll show you different signs radiographically of osteoporosis, but the description is just going to be osteopenic. To actually diagnose osteoporosis, it requires at least 2.5 standard deviations below what's considered peak bone mass. And that's only measured by a DEXA, a bone scan, or dual energy X-ray absorptiometry scan. This may lead to bone pain. And as they do have this decrease in bone mass, decrease in bone mineralization, that leads to an increased risk of fracture. So as you see in this radiograph, what is the evidence of osteopenia, which makes you think this patient may be osteoporotic? Well, one thing that stands out, the legendary oral radiologist who taught me was Lars Hollander, and he would talk a lot about this sign. We'll see it even more in the next slide, but the external oblique ridge stands out. In this case, not so obvious. But what else stands out? Look at the inferior border of the mandible. Usually that's several millimeters thick, but in this case, maybe only 2-3 millimeters. And just the overall loss of density of bone. You see those signs even more in this case. See that external oblique ridge, how it really stands out? The teeth stand out. Overall, the bone just appears radiolucent, a little bit more like it's see-through, a little bit more like glass. Then the inferior border is a little bit thinned in this case. But what really stands out to me in that image, this panoramic radiograph, is that external oblique ridge. And there are different factors that influence loss of bone mass. One is just age-related changes. As we said, past the age of 30, we're losing more bone mineral than we're gaining. Reduced physical activity. So one good reason, not only for muscle development, but also for maintaining strong bones, it's a good reason to work out. So mechanical force not only stimulates muscle growth, but it stimulates bone growth as well. Genetic factors are going to play a part. Calcium nutrition state. You've got to maintain adequate levels of calcium and adequate levels of vitamin D throughout our lives. Any restricted calcium or vitamin D levels throughout our lives is going to limit our peak bone mass, and that's going to make us more susceptible to osteoporosis in the future. So increased calcium or vitamin D intake, sun exposure. I forgot to mention this in the last video when I was talking about vitamin D, but most of us cannot get adequate levels of vitamin D without also having some levels of sun exposure. And so if we don't have adequate levels of sun exposure, that's going to cause a decreased bone mass. But we want that increased peak bone mass, which provides a buffer against osteoporosis in the future. Then also hormonal influences. So in women, estrogen deficiency in postmenopause. For men, it's associated with low testosterone that can accelerate osteoporosis. And so just remember that one. Osteoporosis is the most common cause of decreased bone mass. You're going to see that in your patients. If you see 70, 80-year-old patients, you'll probably start to notice in the panoramic those same signs that I showed you of the jaw. And you're definitely going to start to recognize signs of osteoporosis. So we should talk about rickets, osteomalacia. These are both manifestations of vitamin D deficiency. It's just that one is in children, rickets is in children, osteomalacia in adults. It can be related to abnormal metabolism. So in the last video, I talked about the metabolism of vitamin D. If we don't have healthy, liver and kidneys was the second one, we're not going to have adequate amounts of the active form of vitamin D in our system. And that's required for normal calcium absorption in the gut. So in children, rickets, that's going to interfere with deposition of bone and growth plates. And that's what leads to this classic outward bowing appearance of the legs that you'll see with rickets cases. In the growth plates, it's not depositing enough calcium, enough mineralization. And so the bones aren't growing correctly and they tend to grow outward, bow outward. Then in this case, is this a child or adult? Well, they do have crowns on their teeth. Their pulps are pretty nice and plump. That tells me that it's not a terribly old patient. Probably not old enough where I would expect to see a great degree of osteoporosis in most cases, but look at the bone here. Where is it? Where's the nice cortical alveolar crest? Where's that lamina dura around the teeth? They're pretty much missing, and you don't even really see the trabeculation, partly because of the image quality, but it's just a very low density bone. Maybe a middle-aged patient, younger than I would expect to see this degree of osteoporosis. And so this is a case of osteomalacia in adult. Leads to low bone density, does predispose to fractures, but it is a different process than osteoporosis. Radiographically, it may look just the same, but osteoporosis tends to lead to porous, brittle bones, while osteomalacia tends to lead to softer bones. So if I were to guess, I would say osteoporosis is even at a higher predisposition to fracture. All right, this is from a website I found last year when I was preparing for this lecture. I may have gone down a little bit of a rabbit hole, but realizing how common vitamin D deficiency is, it's a lot more common than we may recognize. And it may lead to a lot of different things. Some of these may be associated with a resulting calcium deficiency that can lead to mood changes, but joint pain, bone loss, meaning mineralization loss in the bones, muscle weakness, aches, cramps, even hair loss, and of course fatigue. And so this is the rabbit hole I got into. This is a link, if you want to follow it, to a health article that talked about how common osteomalacia was in adults. And even particularly, here we talk about melanin absorbing the UVB rays, which we talked about in the previous video. It protects skin, but it also blocks those rays from forming that pre-vitamin D that's needed to form a substantial amount of vitamin D in most people. And so dark-skinned people are particularly at risk. They require 10 times as much UVB radiation to produce the same amount of that pre-vitamin D as a light-skinned person. So they're at 15 to 20 times higher risk of vitamin D deficiency. In the US, about 42% of adults are deficient in vitamin D. I didn't realize it was that high until I started reading more about it last year. 50% of children between 1 and 5 and about 70% of children between 6 and 11 have vitamin D stores. And it's even more severe when we talk about people with dark skin. Nearly 63% of Hispanic adults, 82% of African American adults are vitamin D deficient. And so what does it do when we're vitamin D deficient? That's going to decrease the absorption of calcium and phosphate from the gut. We see vitamin D, the active form of vitamin D, is what causes increased resorption in the gut, helps us get more of both of those minerals from our food. And if that leads to hypocalcemia, because we're not getting enough calcium now, that may activate the parathyroid hormone inside the parathyroid glands. And parathyroid, we said, was the calcium Nazi. That's going to draw calcium out of bones. That's going to increase bone resorption. And so think of bone as your calcium store. And PTH is activated. It starts to draw that calcium out of bones. And that's what leads to that decreased mineralization in the case of osteomalacia. PTH also is going to expel phosphate and retain calcium in the kidneys. So that's another way that it tries to maintain those calcium levels. In this case, calcium level is, and a lot of times, maintained because we're increasing resorption out of the bone. It's holding on to it as much as it can from the kidneys. But what you're going to see in vitamin D deficiency is phosphate may be low because it's holding on to calcium at the expense of phosphate. And that leads to reduced mineralization over time. Whenever you have long-term activation of parathyroid hormone, that can lead to decreased calcification in the bone over time, which is not healthy. And so what would the lab values be for rickets or osteomalacia? Remember, both of these are vitamin D deficiencies. And so what effect is that going to have on calcium? Well, you may think it may go a bit low, and it might be low, but remember, calcium is tightly controlled. And so as soon as calcium starts dropping just a little bit, what happens? Calcium has an inverse effect on parathyroid hormone, so PTH is increased. So PTH is most likely going to be high. Calcium is going to be low to variable because of that tight control of the PTH. But if you have continually low calcium, it's continuing to stimulate the parathyroid hormone to produce PTH. And so that's going to be high. What about phosphorus? Remember that one? That one's a little tricky, but I said the way I kind of remember this, as far as the kidneys' effect on calcium and phosphate, if kidneys are being stimulated by PTH to hold on to more calcium, it's doing that at the expense of phosphate. I don't know how accurate that is, but it helps me remember. And so it's a good thing to remember since phosphate levels are actually going to be low. But again, that's something that's variable. And so I think the big one here is PTH and low to normal calcium levels. What about alkaline phosphatase? Remember the one I told you to really remember for that. If it's super high, everything else relatively normal, that would be Paget's disease, but it may be high in other things. And whenever there's higher osteoblastic activity, ALP is going to be high. And this is one of those diseases where it could be high. So Rickets osteomalacia may have high ALP. Most of these are variable, but definitely I would say you're going to have high parathyroid hormone and low to normal calcium levels. And so our penguins of Madagascar friends were correct. You got to get that vitamin D, boys. It's necessary for good, healthy bone turnover. We want to have good calcium stores inside our bones as we age. And that's why we started to fortify certain products with vitamin D as well to help us get a little extra. Little thought question for you here. Is this going to be an image of rickets or osteomalacia? And so look at everything you can see in this image. You might first start looking at the bone because we were talking about osteomalacia leading to osteopenia. The bone looks somewhat normal, but what about the dentition? How do these teeth look? These roots not really formed. This enamel almost looks like something like amelogenesis imperfecta, just not very well formed, not very well mineralized. And so this is clearly a child, and it's something that affected development of teeth. And a vitamin D deficiency, when teeth are developing, may lead to something like this. It can look really similar to AI, amelogenesis imperfecta. Also can affect the development, the eruption of teeth, as you can see here. And so these are the dental findings that you'll see with rickets: delayed eruption, malocclusion, and as I just pointed out here, dental and enamel defects, increased carie because it's not as mineralized as it should be, so that it increased caries risk. All right, the last one I'm going to talk about here is scurvy or vitamin C deficiency. And we don't typically think of this as a bone disease. It's really more of a soft tissue disease because what is vitamin C used for? Mainly it affects collagen formation. But of course that can affect bone formation because that requires collagen as well. So if it impairs the osteoid matrix formation, then it may affect bone and it can lead to osteoporosis. But mostly we think of this as a soft tissue disease, really causes or can lead to gingivitis. In some cases, subperiosteal hemorrhage. And so I won't focus too much on that. Just know that vitamin C can lead to a form of osteopenia / osteoporosis. All right, thanks, and see you on the next one.